Okay, welcome everybody to this webinar by Ash. Those of you who look carefully at the agenda will have been expecting Dan Poulter, who's a doctor and member of Parliament, but unfortunately he's unwell and unable to participate today. So this is an issue close to his heart, so we'll be keeping him up to speed. But you've got me rather than him. Now, John Waldron for Ash has briefed me very well, so any mistakes are mine and not his. I just want to start off by welcoming you all and by saying this webinar is really about building on the progress that's already been made in moving away from a culture which supported smoking in mental health settings to a culture which supports quitting. This has meant challenging what was a widespread assumption that smokers with mental health problems don't want to quit, or that quitting would be too difficult for them, or would actually undermine their mental health, and when in fact we know that for all those things the opposite is true. So we urgently need to reprioritise smoke-free policy implementation because of the disruption of the pandemic, to see if we can carry on that path and make sure the long-term plan is implemented properly, and that smokers with a mental health condition aren't left behind as we move towards a smoke-free 2030. So today's event is an opportunity to hear about progress being made towards smoke-free mental health services across the country, and to understand the challenges and opportunities faced by services in implementing smoke-free mental health settings. And lastly, to reflect on the role that mental health services can play in driving down smoking rates among people with mental health problems. So we're going to hear from experts on public health, as well as examples from those leading on delivery around the country. And we're delighted to have, I'm not sure how many we have now, but we had over 200 people signed up. And we know that the recording will be watched by many more subsequently. So if we can move on to the next slide, Amy, and I'll go through housekeeping. As I've already said, this meeting is being recorded and the event will be circulated to all attendees and uploaded to the Ash webinar page after the event. Can all panelists and attendees keep themselves muted and turn their videos off unless they're presenting? Ash staff will mute anyone who's unmuted and not presenting. All of you are encouraged to submit questions and reflections in the meeting chat, which we can bring up during the Q&A session. So, the agenda. First of all, we have insights from Ash's 2019 report on progress towards smoke-free mental health services from Hazel Cheeseman. So I'm going to hand over to Hazel now.
Thanks, Deborah. Amy, I don't know if you've got my slides or if I'm sharing them. Do you want to share?
Amy's going to share them, Hazel.
Okay, great. Fine. I'll wait for...
And can we post the agenda in the chat? Because I went through it very quickly.
Yep.
Oh, I think we might have lost Amy. I will share my slides. Never as straightforward. Right, hopefully everyone can see those. So I'm going to talk about the progress that we've been making towards smoke-free mental health settings and reflect on some survey work that Ash has done over the last few years, and kind of position that in the context of NICE guidance being updated, and of course the NHS Long Term Plan commitments to deliver a tobacco dependency treatment service across mental health settings. So just a quick kind of reflection on that. So, you know, why does the smoke-free context matter in this wider kind of policy context? So obviously we have this commitment to implement the treatment pathway in mental health settings by 23-24, and really what the presentation is aiming to do today is to reflect on how that smoke-free context is an enabler for ensuring that we get the most out of implementing that pathway. But also, we had a national target that was set in the government's 2017 tobacco control plan. The mental health setting should be smoke-free by 2018. So kind of quick reflection on the extent to which we had achieved that and what might have happened through the pandemic, and to reflect on the update of NICE guidance and to put this all in context. So I'm going to start with just a quick review of the NICE guidance. So these are slides borrowed from colleagues at NCSTT. We ran an event a few weeks ago with them where they talked in more detail about the guidance, and possibly we will come back to the NICE guidance in the future in more detail and take a deeper dive from a mental health perspective. But these are just a kind of a quick overview. So really there's, this new NICE guidance brings together lots of existing guidance that was out there on tobacco into a single document. And there's a lot that has continuity with the past, and this isn't a kind of radically new set of guidance from NICE. The core elements of it are will be very familiar to those of you who are familiar with the previous NICE guidance. So it talks, of course, about combination of behavioural support and stop smoking medication being the evidence base of supporting people to stop smoking, that stopping smoking in one go is the best approach, and the training standards kind of remain common with the past as well. However, there are some new things in this guidance and new things which are really relevant in the mental health context too. So there's much more in this new guidance about tailoring quits around the needs of the smoker, and there are various elements that are encouraged in relation to that. So particularly flexibility around the use of medications and NRT, a strengthened recommendation around advice to you around e-cigarettes and using that as a first-line quitting aid. Clearer guidance around NRT in pregnancy is a little less relevant in this context, and an integration of the previous harm reduction guidance on tobacco that NICE already had into this kind of broader suite of materials around helping people to quit. So in essence, what the new NICE guidance is really that first point. It's a focus on taking a more tailored approach to our smokers, and that's really, really important in the mental health context, because what the NICE guidance says that's specific to the mental health population is that people with mental health conditions may need more tailored support, may need longer support, may need more access to medication, and all those things should be taken into account in the provision of services. It also reiterates the NICE guidance, the commitment to smoke-free settings in secondary care, and the importance of having plans in place which both support staff and patients to temporarily or completely quit smoking. It promotes training for staff and things like the removal of shelters and outdoor spaces for smoking, and calls for staff not to be smoking during working hours, but to be supported to do so. So we ran a survey in 2019 commissioned by Public Health England to look at the implementation of the previous NICE guidance. And as I say, there's a lot of continuity with the previous NICE guidance with what we have now. So the survey results, I think, very much, would speak to the new NICE guidance. We had quite a high response rate. We managed to get responses from 83% of trusts that we sought responses from, and I'm also going to reflect in here on some separate survey work that we did looking at staff skills, I'll reflect on that as we go through. So smoke-free policy implementation. So this is the implementation of having smoke-free sites and obviously smoke-free indoor spaces. So when we did the survey in 2019, we found the majority of trusts had a smoke-free policy in place, prohibiting smoking on wards and hospital grounds. But there were a minority of trusts, 18%, that still permitted smoking in courtyards and designated areas on hospital grounds. And what the report identified was some key enablers and barriers to those policies. So the enablers, lots of this will be familiar, I'm sure. Leadership and staff support were absolutely crucial for successful implementation of the policy, but also, the availability of e-cigarettes was seen as a really important enabler, and we saw a variety of approaches to e-cigarettes in mental health trusts. And training was also seen as a kind of crucial prerequisite to making smoke-free policies work. Barriers are, will not be a surprise to many of you in mental health settings. Staff, the appetite that staff have, again, kind of linked quite closely to training. Patient resistance, lack of understanding from patients about this, about feeling unsupported, etc. Lack of leadership, and not enough resources to make the job work. In practice, most trusts saw breaches. Most places saw breaches most of the time, but that wasn't the extent to which breaches happen varied across organisations. So some saw many more frequent breaches than others. So about half of trusts were seeing breaches at least once a week inside, in kind of beds and bathrooms. Around 20% were seeing breaches where patients were smoking in outdoors and wall courtyards. And then what we found is a very high use of Section 17 leave to facilitate smoking breaks, and also some additional challenges that people were facing at the boundaries with other organisations and who might have different policies, and also issues around litter. Just to reflect on the kind of variability around policies, how often staff were accompanying patients on smoking breaks was varied quite a bit, but it's striking that back in 2019, nearly 60% reported that at least once a day staff were accompanying patients on smoking breaks. Something that's definitely not in the spirit of the guidance from NICE, and you can see how this is inhibiting when we're rolling out tobacco dependency treatment services to have smoking being facilitated in this way. But of course, the NICE guidance isn't only about smoke-free policies, it's also much more importantly about treating people effectively. So we obviously looked at this in our survey. So we found lots of, the majority of trusts were already providing on-site support ahead of the tobacco dependency treatment services being rolled out. But a minority had a dedicated smoking cessation service. So, hopefully that's something that we will see addressed into the future of this new investment. And other things which hopefully the tobacco dependency treatment services can help us to address is the fact that, the evidence-based medications were not being routinely made available to patients. Less than half, in fact, with the evidence-based best practice medications. But also quite concerningly, quite a high proportion of trusts that they don't always ask patients their smoking status on admission, and establishing a patient's smoking status on admission, quite important in terms of making sure that they have the right support in place. We found that local authority community services were not always available for people with mental health conditions, and 62% of trusts had made some investment in their own community stop smoking support. So there was some out there, but clearly variability in that space. Right, so I don't have an enormous amount of time left, so I just want to think about some of the other challenges for making kind of smoke-free policies work and making our efforts to reduce smoking within mental health settings most effective. And training has been identified as a bit of a challenge in this space. So we did this survey work in 2019, looking at psychiatrists and mental health nurses in particular, and we found again both a gap in terms of whether people reported having training, more common among mental health nurses and psychiatrists, but also a gap in terms of people's knowledge and understanding. So people would report to us that they had been trained or did have the skills to deliver VBA, but when the VBA task was broken down to them, they weren't able to kind of respond to that correctly. So their understanding of what VBA was perhaps not accurate. So people, for example, found it most difficult to report that they were able to give people a referral, for example. But this just reflects the kind of variety of understandings among psychiatrists in terms of training. So this shows the proportion who said they haven't had training or don't remember if they've had training against a range of different areas. And so behavioural support for smoking cessation very unlikely that psychiatrists have had training in that space. Medication also quite high, other smoking cessation medications like varenicline and ibuprofen, pretty high rate of people either not having the training or not remembering the training, and also e-cigarettes, very high proportion there as well. So of course this makes implementing our new tobacco dependency treatment pathways that bit more challenging when our existing workforce do have quite big gaps in their knowledge and understanding in some key areas. I think I've probably just spoken to most of these bullet points here. So yes, not only was the some of the knowledge and understanding concerning, but the evidence around kind of misperceptions about smoking, quitting. Deborah was talking at the top there about people's perceptions that people either don't want to quit smoking or can't quit smoking, and those remain common among the nurses and psychiatrists that we surveyed. But another really important thing, and I think back to the survey findings around smoke-free policies, is that what many people were reporting was organisational structures and norms that were really inhibiting people's ability to put training that they did have into practice, or indeed to participate in training in the first place. So my final few slides, I think, looking at e-cigarettes. So clearly that's an issue that I think we'll probably come back to through the webinar today. And our survey in 2019 found differences in terms of the policies that people had in place. So most trusts were allowing the use of e-cigarettes, but there was quite a bit of difference in terms of what that actually looked like in practice. So quite a few trusts had restrictions on the types of products that were in place, and many had restrictions on where they could be used. But there were kind of sort of significant group that were providing e-cigarettes free to their patients. And I think if we were to repeat the survey now, we might find that that there was a growing group in terms of the provision of e-cigarettes. Certainly that's my impression anecdotally. And one of the things that might have also helped to drive change, it's to be hoped, is that the Science and Technology Committee, I think that might be the wrong date on it, unfortunately, they did a inquiry on e-cigarettes, and they looked particularly at the use of e-cigarettes in mental health trusts, and they concluded that there should be some clearer guidance around the use of e-cigarettes and that they should be better enabled. And to support that recommendation, the Mental Health and Smoking Partnership published this guidance, which is linked to here, in 2020. And you know, that's something that hopefully is being more consistently done through mental health settings, and will be an important enabler as we move forward with rolling out the tobacco dependency treatment services. And it's important to reflect that NICE guidance has been updated to strengthen the advice to healthcare professionals around e-cigarettes. And we're going to be revisiting e-cigarettes in more detail in a few weeks' time in April with a focused look at e-cigarettes. And then just to think about what some of the challenges have been around COVID-19. So we have anecdotally heard reports that policies have been rolled back in some places because of COVID. And you know, that's obviously a cause of concern, and clearly the whole system has been under enormous pressure over the last couple of years with the impact of the pandemic for various reasons. But there's also evidence about what might be happening to people with a mental health condition. So there are a couple of different survey sources which seem to show similar things, which are that people with mental health conditions, when they have tried to quit during the pandemic, most of this survey work was from the first year of the pandemic, from 2020, they were quitting with greater success. But among those that were not quitting, then consumption of tobacco appears to have increased, and there's more smoking inside, etc. So there's a bit of a kind of polarization perhaps in smoking behaviours in our population, and so there's a real risk that some of these very entrenched inequalities are being exacerbated through the pandemic, and on top of that, the disruption to services through the pandemic, maybe, you know, compounding that. So I've already gone over time. So just to my last slide, just to say that as I've been saying throughout, implementing the NICE guidance is an enabler to making our tobacco dependency treatment services work as well as they can. It's important, the cultural and environmental context for putting these services in place and making them a success. Through all of the different pieces of survey work we've done, that's consistently come back as both a barrier and an enabler to making these things work well. We need to make sure that we have lots of tools in our toolbox if we're going to do something about smoking in this population. That includes the provision of e-cigarettes and smoke-free grounds, and seeing these things as working together to try and create new norms around quitting and not smoking, challenging our kind of past norms around enabling smoking. And I didn't have time to talk to them today, but I've got some, the information about what's out there in the community, in the in local government and in primary care is a really important part of the jigsaw, and it is currently underserving this population. And I will circulate these slides afterwards, and I've put links to lots of the stuff I've been talking about, and I will stop there. Hand back to Deborah.
Thanks, Hazel. And actually, because I shaved some of my time, you've come in under time. And don't worry, it was 2018, the Science and Technology Committee. It's been 4 years since it reported, and it took a long time to go from that recommendation to guidance being developed and issued. I'm now going to hand over to our next speaker, Mary Yates, who many of you will know, and we certainly know very well, nurse consultant and smoke-free lead at South London and Maudsley. Mary's going to update us on the introduction of an integrated smoke-free service model at SLAM. So I'm handing over to Mary.
Thank you so much, Deborah, and what a wonderful start to our event with Hazel's overview of where we're at. I'm not going to say too much about SLAM apart from that we are in South London, obviously, and I'm speaking to you on behalf of the team that I work with there, and of course mostly the patients that I've learned such a lot from. I was particularly asked to focus on restrictive practices and how we've been able to juggle the need to be least restrictive as possible whilst implementing a smoke-free policy. So next slide, please, Amy. I'm going to speak to you about how we started our smoke-free programme, what we've been learning as we go along, and how it's going now. So next slide. And please give another click. So traditionally, we have been completely rubbish, and I must say myself, I've been particularly rubbish and spent most of my career undermining health by restricting access to tobacco dependence treatment. So shame on me. I am just devastated when I look back and I think about all the damage that I have done. We have been actively restricting this life-saving treatments from sick smokers for decades and leaving people with mental health problems to develop completely preventable disease and to die young. And so I'm absolutely delighted that the new NICE guidance brings everything together for us and really sets out a very clear way for how we need to now at pace get our patients back on a level playing field with everyone else in the community. Next slide, please. So I think what we heard from Hazel is that a key foundation stone for all of this work is about changing the hearts and minds of staff, because she mentioned that was one of the big barriers. In fact, that was the major barrier to progress when it comes to introducing tobacco dependence treatment pathways. And so this is about having lots and lots of conversations about tobacco dependence treatment, about why it's important. When I'm having these conversations, I use what I call the EPE model. So not saying that I am an expert, because I'm not. I am, a human being with some life experience, some lived experience, and I need to get alongside people who are struggling with this issue, elicit from them what they already know about tobacco dependence, ask for permission to tell them something about what I know, and then based on their listening, elicit from them what they want to do with that information that I've shared. So it's about creating and holding the space for having these conversations about what a difference tobacco dependence treatments can make to people's lives, to our communities, and to our services. And talking about why that's an important thing, and then showing people what they need to do differently. We all need to change our behaviour. We are talking to patients about changing their behaviour when it comes to smoking, but we need to change our behaviour, the way that we've organised services and the way we've prioritised things in the past, and changing the system to accommodate these new routines, and then catching people when they do the right thing and celebrating those successes. I like having tea and cake with people when they stop smoking, so it's just a joy. When you're changing the culture, you've got to focus on lots of different things at the same time. So I think it's like having a kind of a scattergun approach. Of course, you need that education and training for staff, and you need to do that in lots of different ways. So some e-learning, some team-based training, some one-to-one training, and some classroom-based training. Oh, to be able to get back into classrooms. This week, I've been able to get back into the classroom, and it's just so exciting to do that after such a long time. We also need to have some really flexible treatment pathways, and what we've started to do now, and we've been doing it since the beginning of 2020, is integrating our care. We know how important relationships with caregivers are, so our tobacco dependence treatment advisors work with smokers, not just when they're in hospital, but they follow them through across that high risk relapse point at discharge and beyond as they get settled back at home. We also need lots of support for implementing policies and enhancing the infrastructure around the policy, and of course having good data and looking at our activity and our outcomes. And everything we do must be in step with what our service users and their families want. Next slide, please. So you will all be familiar with this, but I think it's always worth reminding everyone about the 3 A's, the importance of asking absolutely everyone. And I saw that again in Hazel's slides, a reminder that so few people are even being asked yet if they smoke, and then giving advice. And again, I make no apology for reminding you all about how to do that. Please do not ask people if they want to stop smoking, because as they're being admitted to mental health service, that's probably the last thing on their mind. But do tell them about what advice and what support we have available to help them with their smoking during their time with us. So if you tell someone that they should stop, they must stop, or they ought to stop, that's just going to create resistance. So getting that right and making sure everyone's doing that advice correctly is a really critical point and must be embedded across all of the services. And then, of course, connecting smokers with those specialist trained advisors. And I'm very delighted to say that we've now got 14 advisors working all across our organisation in an integrated way, which is fantastic. Making those options available. Not everyone will want to quit, but as Hazel said, quitting completely in one go is the best thing to do if you can, but if not, then let's help you to cut down, or let's help you to temporarily abstain. Next slide, please. And one of the things that we have done, if you please click again, you will see how we've translated that ask, advise and act into our infrastructure. So we've embedded that system of ask, advise and act into our electronic patient record system. So the referrals are automatically processed and then sent to the relevant place. Our staff are very busy and they don't have time to fill in referral forms, so this system works so smoothly and quickly. It's wonderful, making sure that those referrals go to the local stop smoking services or to our hospital-based services as well. So next I'll tell you about just a few of the barriers and the restrictions that we've been able to remove. If you could move on, please, Amy. Thank you so much. And just one more click, there we go. So those restrictions that we've focused on removing have been trying to get that data then from the system back into the hands of the people that are referring. There's nothing worse than referring somebody to a service and then not hearing anything about it. So seeing that data and having that to use can be a really powerful motivator for staff who are very busy. We also removed restrictions around access to NRT so that our nurses, our registered nurses, are able to administer the NRT without having doctor's prescription. So this means if anybody is admitted, they can immediately get T and NRT on arrival without having a long wait. We think it's really, really important to routinely check carbon monoxide levels. You wouldn't dream of having a diabetic patient in your ward and not check their blood sugar levels. And so it's exactly the same thing with carbon monoxide. It is the carbon monoxide that's going to kill our patients, and they will die 20 years earlier probably than everyone else in the community because of their smoking. So we must stop having this complete blind spot to checking carbon monoxide levels. It's far more important to be doing that than to be routinely checking people's blood pressures because it is the carbon monoxide that they really need to try and get to grips with. We have a very friendly approach to e-cigarettes. In fact, we've been supporting our patients to use e-cigarettes since 2012. So e-cigarettes are given to our patients free of charge, and they get them throughout their hospital admission if they wish to have them, of course, just for adults only. And in addition, we also sell them in our retail outlets. So wherever we have a hospital shop, e-cigarettes are on the shelf there for people to buy at a very discounted price. And we're also now installing smart charging units in all of our wards because we want to remove the barrier to charging e-cigarettes so that patients can independently charge their e-cigarettes and their mobile phones. And I'm so thrilled about this because it's, again, removing another restriction and removing the barrier and promoting independence. It's wonderful. Next slide, please. Now, when it comes to selecting e-cigarettes, this has been quite a journey for us. So we got our smokers involved to help us to think about what e-cigarettes should we make available to them. And the patients told us there were three things that mattered to them when it comes to selecting an e-cigarette. They wanted an e-cigarette that was acceptable. In other words, that managed cravings. We wanted an e-cigarette that was affordable for them because money is a big factor. And they also wanted an e-cigarette that was accessible. In other words, it was available in the local shops. And then we asked our staff what mattered to them in relation to e-cigarettes. And they wanted an e-cigarette that was safe, that they would have confidence in, and that was sustainable. So having a recycling program was really important. So we used the NHS procurement framework, and we selected those e-cigarettes then based on the patient's decisions and what they wanted. Next slide, please. Now, when it comes to continuing
but just to let you know, we're running out of time, so
okay.
I'm
just going to say one other thing that our patients really persuaded us was important to do was to stop storing tobacco, and that's what we've been able to do for a few years now, since 2016 actually. And I'll just go then to my last slide. which is a summary of what I think is really important, that the largest possible health gains can be achieved if we give our smokers access to the best treatments in a prompt way, removing the barriers to this treatment and make it integrated with all their other services. But happy to answer any questions, and sorry if I've rushed at the end. Thank you, Deborah.
Sorry to push you on. But our next speakers are Ogechi Anokwuru and Sally Macvinish from the East London NHS Foundation Trust.
Hi everyone. Waiting for the slides. Thanks, Amy. So my name's Sally Macvinish. I'm a public health registrar based in East London Foundation Trust, or ELFT. Excuse the acronym, I'm probably going to slip into saying that. And I've been in ELFT for the last 5 months, and I'm here with Ogechi.
Hi everyone, I'm Ogechi. I'm the tobacco dependency lead at ELFT, and I've been with ELFT for 3 years, going on 4 years now.
Next slide, please, Amy. So today we're going to talk about our experience as an early implementer site for the new model for tobacco dependency in mental health inpatient settings. I'm sure most of us on the call are aware that the NHS Long Term Plan has a commitment to providing stop smoking support to all inpatients, including those in mental health settings. And with that in mind, we had an aim to increase the proportion of people discharged from our settings who had quit. So before COVID, we were an early implementer site to test and learn a new model. And many of you will have heard of the Ottawa model. We've heard it discussed by Hazel and Mary just now about the importance of 3 things. So systematically identifying all smokers, systematically offering pharmacotherapy and behavioural support to the smokers, and then for people discharged from mental health inpatient settings, following them up with that support into the community post-discharge. Next slide, please. We know that this is important in ELFT for a number of reasons. We have really high smoking prevalence. So looking at our data in Bedford, for example, almost 50%, and Newham and Hackney, 57% smoking prevalence. We can also see from our data that, for example, looking at the left-hand graph there, the green bars show that we are really good at offering very brief advice, but that smaller proportions of our service users receive referrals to stop smoking services. And there is some variation between our geographical directorates because we cover a large footprint, so there's indication that we've got room for improvement there. If we look at the right-hand side, you can see this is data from smokefree Hackney. So this is data that shows how patients drop off once they are referred to the service. So the top green line is for all service users referred into that service over a 1-year period. And you can see that there are patients that drop off because they lack the right contact details, they don't live in the right area, they aren't contactable, and maybe they don't accept the service. But the red line is for our ELFT service users, and our particular population shows that we have a particular problem with referring into our community services, which is why we need that post-discharge support. Next slide, please. I'll pass to Ogechi for the first bit.
Thanks, Sally. So before the IOS funding and the new model, we had set up the service with 3 advisors per the directorates, because we cover Hackney, Newham, Tower Hamlets, and Bedford and Luton. And we also managed to train staff on a regular basis to level 1 VBA, very brief advice, and level 2 support. And in the midst of that, we also designed clinics across all the wards and across all the units where tobacco advisors will have clinics set up to see patients on a regular basis, and even pop-up clinics if the wards can be unsettled. There were concerns about vapes being introduced. So per the e-cig policy, we permitted vapes across the trust to be used.
So as you've just heard from Ogechi, ELFT was in a reasonably good position by having a bit of a tobacco dependency service in place, or not a bit, a good tobacco dependency service in place. And what this early implementer site funding and new model would do would be to build on that and expand. So we had some program managers in place which were running work streams to deliver this, which focused on data, recruitment, access to NRT and VAPES, and peer support. Next slide, please. So you can see from this very busy slide the overview of our draft service pathway. So there are 4 horizontal lines which describe the different work streams. You can see there's activities for our tobacco advisors, so Ogechi and her colleagues, our peer support workers, pharmacotherapy, so NRT and VAPES, and our data and information flow. There will be activities along the way when service users are admitted, during their inpatient stay, at discharge, and then 6 weeks post-discharge. And at that's the time during which they will have ELFT, so they will have ELFT tobacco advisor support. If the service user continues to want ongoing support or access to pharmacotherapy, they'll be transferred to our colleagues in local stop smoking services. Just a highlight on the peer support element, this came through as really important during consultation on the model, and this really is to engage our service users in meaningful activities that helps to address some of the wider determinants of their smoking. So disruption to social isolation and boredom. We've heard nice anecdotes of people joining cycling clubs and boxing clubs, and that being a bigger determinant of them quitting or reducing their tobacco intake than some of the other things that we offer. So that's something that we're really excited to get going with. The other nice thing there is about modelling behaviour, so having a peer support worker who has lived experience of being an ELFT service user who doesn't smoke disrupts some of the norms around smoking. Next slide, please. So I think what's interesting to cover here are some of our challenges and enablers. So as you can see, there is a lot to this model, the 4 different work streams, all of which have a bit of complexity, and having continuity of a program manager, it would be really helpful for that, just so that learning can kind of be embedded and those relationships can be built. And due to various factors, we've had a bit of discontinuity, so it's been a little bit stop-start.
And just carrying on from what Sally was saying, so with the vapes, as you know, the culture around, the staff culture in particular around vapes is still hit and miss, despite being informed from Public Health England and Department of Health that it's 95% safer. There's been a bit of a challenge amongst certain staff groups that they don't feel confident or safe enough for vapes to be used. That's one of the challenges. Also, the logistics to ensure that every directorate is ordering per their ward budget, and equity of access. This was discussed earlier. So some patients may not have access to certain vapes. Some patients are unable to use a particular type of vape. So I think the vape issue is hit and miss at the moment.
Absolutely. And I think we know it's important to support previous inpatients after discharge, because that's a particularly vulnerable time where they drop out of our services. But the complexity of the community pathway does make setting up the service quite tricky. So we've got different borough services, all which have different commissioning agreements, different provision on whether they give vapes and how long they give NRT for. So there's different relationships and standard operating procedures that need to be established with the borough services, as well as our own ELFT community services. So I think the community side of this is something that requires a bit of input.
And with having said that as well, COVID-19 has severely impacted our services, with a lot of our patients having COVID-19 and treating COVID-19 as a priority, as well as them being smokers. Majority of them is also ensuring that they are getting their nicotine dependence treated as well, and their risk of being admitted is a lot higher compared to the non-smoking patients.
Yeah, absolutely. And when it comes to data, we've got kind of 3 things to think about. We need to be able to share information in a meaningful way across the whole pathway, so our advisors can make informed decisions about how to manage service users and work with them. We need our own monitoring and evaluation from a programme point of view, so we need data to inform that. And we also have NHS England and improvement requirements for patient-level data to be sent up nationally, which has required quite a lot of engagement with our business intelligence team. And it's not something that we normally do in inpatient settings. There's been a bit of nervousness about reporting patient-level data and discussion on that. Next slide, please. But we have had some enablers to this. So within ELFT, there's a quality improvement team, and in the early stages of developing the model, using their expertise was really helpful for identifying some of our drivers and some of our change ideas for implementing this.
And with the current tobacco dependency advisors in place, it's given us a head start in terms of making sure all patients are seen. So making sure every contact counts, and ensuring that as the service expands, there'll be more advisors and more staff available to meet the demands of patients with tobacco dependency.
We've also, as a trust, been able to capitalise on some of the well-established processes, so people participation, our use of peer support workers and apprentices, to try to build this service model in a way that's quite inclusive of our local community, our service users and our staff. Which is something that I think will really enhance the model going forward.
And finally, we have got senior buy-in, so clinical directors, senior staff, senior managers are very keen to reduce smoking rates across the trust, and also to adhere to guidelines per policy and ensure that patients' needs are being met.
That's all from us. Thanks very much. Happy to answer questions in the Q&A.
Thank you both so much. Our next speaker is Aideen Dunn, who is the National Medical Director's Clinical Fellow at NHS England. And Aideen is going to talk about the model being developed for community mental health services as part of the NHS Long Term Plan.
Thank you. Thanks, Amy. Hello everyone, and thank you for the opportunity to present. And Deborah, it's really lovely to see you again. It's been a long time since I was in PHE. So I'm here to talk about the long-term plan commitment that focuses on community mental health tobacco dependency services. And I'm going to talk through, I suppose, our journey so far and our next steps, and particularly looking at our strategy around our early implementer sites. Next slide, please. Thank you. I know everybody on this call knows why this is important, but amuse me for a while I just kind of run through some key facts. So we know that tobacco is a key driver of health inequalities in the general population, but this is especially true for people with severe mental illness. And apologies, I'm going to abbreviate to SMI if that's okay. So it's estimated that around 50% of deaths in people with SMI is attributable to smoking. We know that in the general population, smoking rates have reduced year on year, and in 2019, figures indicated that smoking prevalence in the adult population was around 13.9%. Unfortunately, in people with a mental illness, it's significantly higher, and there's also a trend that with increasing severity of mental health illness, there's an increasing prevalence of smoking. So, for example, in people with anxiety and depression, the rate is around 25%. In people with SMI, it's around 40%. And studies have recorded rates as high as 70 to 90% in patients with psychosis and schizophrenia. So it is a significant issue and rates are really high, so it's important. But one of the challenges we have is that smoking is a complex behaviour in people with SMI, and it's considered as a behaviour that's deeply entrenched. So people with a mental illness are more likely to be more dependent and heavier smokers, and it's estimated that around a third of all cigarettes smoked is by somebody with a mental health illness. So in recognising this, there is evidence that standard tobacco treatment services are effective in people with SMI, but echoing exactly what Hazel said earlier, and I think that the narrative coming out of the recent NICE guidance is that actually we do need to think about tailoring our services that people with SMI have a different set of needs, and therefore there is a need to look at how we reorientate or reconfigure the service around their needs. And the Scimitar trial showed this, that when you have a bespoke service, you have better outcomes, and they demonstrated better quit rates at 6 months. Next slide, please. So, oh, thank you. So something that's interesting with the LTP commitments, they're very much focused on, you know, establishing better treatment options. So looking at the inpatient offer, making sure that when people are admitted that they have immediate access. But if you take a step back, and again, it's been talked about on this during this event, we're looking at place-based approaches. So the inpatient offer for both mental health and acute settings, and also the maternity pathway, are very much focused on place. And we know place is important because where we live, where we work, where we play impacts on our health, and it shapes our opportunities to be healthy. And so the long-term plan commitments are important because it's about the right treatment options, but it's also about having the right treatment options in the right place. And so when we talk about the services that I'm focusing on, the community-based services, this is extending place into the local community. Next slide, please. And we know that local communities are equally important in shaping our access and opportunities to be healthy. Next slide, please, Amy. Thank you. So the LTP commitment that I'm focusing on is a universal service for people with SMI, including people with learning disabilities, and this is a community-based offer. And similar to the previous presentation that talked about challenges and enablers, we had some real challenges. So we had a line in the LTP plan that we had to operationalise, and one of the challenges for us was there was no clear universal definition of what good in practice looked like. But there was acknowledgement that there was some evidence around there was evidence that the standard treatment needed to be adapted to be more effective. We've no clear understanding of the cost to deliver these services. Without a universal model, it's very hard to set parameters around the cost, and so we have variations of the service being delivered, but again, we don't have a central understanding of what the service costs are. And then the evidence base for tobacco dependency in people with SMI is less developed than for the general population and for some other high-risk groups. But I think some important enablers that were in our favour was, first of all, we have established expert and reference groups. Oh, shall I share my slides? Okay, let me just share. Right. I'm going to share my oh no, I can't share. Okay. Shall I keep talking?
You just keep going, Nadine. I'll share them.
Okay, thank you. Okay, so some of the challenges that we had, I've talked about. So some of the enablers that we have was that there were established reference groups. So just the previous slide, John.
This one or
Then the one before, please.
Sorry.
Sorry, no, that's you've gone back to. So one, yeah, that's it. Thank you. We have very passionate stakeholders that are engaged, and this really helped create momentum. We do have some excellent examples of services that are being delivered that we could learn from. So we weren't starting from scratch. So when I say there's no universal definition of what good looks like, that doesn't mean there isn't good happening. It was just that we weren't really capturing that systematically. And as they talked about Scimitar, we do have an example of a robustly tested intervention, and that's really important because it gives us high quality evidence that we can refer to. And so we've been working with stakeholders and academics and key organisations to help develop a service model that we've been testing. So the next slide, please. So what's on this slide is following kind of a series of engagement. We've defined, so NICE guidance is, you know, that stands. You must have services that align with existing NICE guidance and most recent NICE guidance. But this is kind of, in terms of what does that tailoring bit look like, this is what we've tried to define. So a proposed model of good practice would systematically identify people that smoked and offering that opt-out referral. that your services are delivered by a staff smoking advisor with mental health expertise or experience, that clients are offered a duration and intensity that's tailored to their needs, that all NICE recommended treatment options are available, flexibility, and this is in terms of when they set a quit date, incorporating a harm reduction approach, structured quit down, flexibility in terms of how and where appointments are delivered, that communication link with medicines management, so informing the clinical team of an intention to quit, informing them of updates that might result in a medicines review, and also that continued support after the client quits smoking. We've also recognised that at a local level, so we can try and define best practice at a national level, but at a local level, there are some decisions that are probably best made at that level. So, for example, whether a partner or carer is referred into this tailored offer of support or whether they're referred into a local stop smoking service, whether services appointments are given in the home, whether local systems have the capacity and resources to do that. So we can't be too prescriptive, and we actually can't be prescriptive at all, but what we can do is benchmark what we think good looks like. So next slide. We've also recognised, and again it goes to the point that's been made several times, the really important to systematically identify people, assess their smoking status and then refer into appropriate treatment. And so alongside the service, we recognise the need to identify potential pathways that these services could sit in. And these pathways are designed to sit alongside or with existing infrastructure relevant to people with SMI. So there are 3 pathways that we're looking to test. There is one co-located with primary care, building on the physical health check for people with SMI. There's one building on the inpatient offer. So ELFT have just talked about the inpatient offer. The community service offers that step down approach, so when they're discharged there's that continuity of service, and then the third option is I've just got very dark. The third option is looking at co-locating with community mental health services, and that's adopting that making every contact count approach. Next slide. So these are our 7 early implementer sites that we're planning to mobilise, and we are in the process of kind of setting up the mobilisation. We have a really good spread across the 7 sites of 2 delivering inpatient, outpatient, 2 delivering primary care, and 3 delivering the community mental health services, community mental health model. On the next slide, it's just a list of the early implementer sites. So if you prefer a list rather than a map, I've now turned it into a white square. This is it. So you can move to the next slide. So in terms of our next steps, so my colleague Hindusha, who is on this call, she's leading on the mobilisation. We are sharing a mobilisation plan with regions to get some agreement on this is what we think the approach looks like, and we're in the process of putting in meetings with the early implementer sites. We're submitting a proposal to NIHR for funding to assess the long-term effectiveness and cost effectiveness of these services, but we're also developing infrastructure and resource to undertake process evaluation to get the rapid learning from the early implementer sites to inform national rollout. And then we're hoping to link in with the existing tobacco dependency patient level data collection that Paul Cillia-Lacourt and Tom Frost are working on, to use that data to do the impact evaluation. We have 3 further task and finish groups that we want to deliver. One is looking at the learning infrastructure that early implementer sites need. The other one that's of interest is co-production. So we really want early implementer sites to incorporate co-production within their approach. And we want to deliver a session to help systems in doing that, and helping to define what does good look like. And then obviously the long-term plan talks about this service being in every system. We have 7 early implementer sites, and the next step is to identify what the plan is for that national rollout, so that by the end of 23-24 we have a service in every system. Thank you, and apologies for cameras and presentation.
No, thank you very much, Aideen, for coming in on time. I'm next going to hand over to Richard Roberts, who's matron at Millview Hospital in Hove, I think, isn't that right, Richard? Who's going to update on the hospital's experience of going smoke-free.
Thank you. Hello, everybody. So my name's Richie Roberts. I am a matron at Millview Hospital, which is an acute mental health unit in Brighton and Hove. We're part of Sussex Partnership Foundation NHS Trust. I'm a bit embarrassed about my presentation, to be honest. It's a little bit more basic than most of the other ones we've seen today, but I'm going to try and tell you about our experience of going smoke-free on Regency ward. Next slide, please. So I'll give you a brief overview of Regency ward. Regency ward is one of 5 wards at the hospital. It's quite a large hospital, roughly 80 beds in total. We have a range of wards within the hospital. We have an acute female ward, an acute male ward, a PQ ward, a dementia ward, and an older people's ward. Regency ward is the acute male ward. It's 20 beds, so quite a large ward. The admission criteria for the ward is obviously working age males experiencing a mental health crisis that cannot be managed safely in the community. I have length of stay on the slide there, and the reason why that is on there is because I believe it does have an impact on our journey. Regency ward has quite a high length of stay in comparison to most other male acute wards. We're implementing a project currently about reducing our length of stay, but I do believe it's relevant because obviously if we have people in hospital for a longer period than average, then obviously it can become more of a challenge to meet people's needs, especially in relation to smoking cessation. The environment, so in terms of the environment, as I say, it's a 20-bedded ward, but what's relevant to this presentation is that that ward also includes an enclosed garden, which is accessible to all of the patients on the ward, and it's a central garden accessed from the central lounge on the ward. Next slide, please. So I have worked in the trust for a while, but I joined the Regency team as part of the length of stay project back in August 2021. When I arrived, my colleague who will be joining us shortly, hopefully, Hannah Cove, joined soon after me as the ward manager. The main focus really was about improving care, reducing the length of stay, but we soon became aware that there was an issue on the ward in terms of people smoking. And we obviously wanted to address that as soon as possible, because obviously, as we're all aware, the damage that can have on people's long-term health. So we quickly identified that that was something that we needed to look at and try and support people on the ward and reduce the smoking that was occurring in the enclosed garden. Okay, next slide, please. So we went through a process. I think it's important for me to say at this stage that this is the process that we went through isn't necessarily the process of the whole of Sussex Partnership, and it's important to kind of acknowledge that this trust is currently in the process of recruiting a whole new team in terms of tobacco dependency, including a new matron and tobacco advisors. So the organisation as a whole is obviously prioritising this and working hard to get things right. Myself and Hannah, we worked together after consultation with other colleagues in different units across the trust on the best way to approach the issue as quickly as possible, really. So back in October, we decided to set a date, which was the 1st of November 2021. And we began a process of linking in with the patients and the staff working on the ward and making preparations to become tobacco free from the 1st of November. There was a range of feelings from both the patients and the staff working on the ward about the launch date of the 1st of November and about becoming smoke free. Some of the concerns raised by the staff were concerns in relation to essentially the challenges that we would face in implementing going tobacco free and the potential risk of an increase in incidence on the ward. But we did our best to kind of to reassure the staff that we would support and review the process as we were going through it, and obviously try to manage any kind of increased risk if it occurred. Next slide, please. So, in preparation, can we go back a slide? Sorry. In terms of the patient information, what we did in terms of liaison and support of the patients on the ward is myself and Hannah, would attend the weekly community meetings on the ward to share the information of the plan to go smoke-free, in order to give people plenty of notice in advance that there would be some changes in terms of the ward and being able to kind of smoke in the garden area. We developed posters and information leaflets for patients, and we would, as I say, we would meet with people regularly during the community meetings and outside of the community meetings to alleviate any anxieties, to try and reassure people about the plan and how we would support them in relation to NRT. So yeah, next slide, please. Thank you. So the 1st of November came. We developed a few changes in the way that we work. So one of the big changes was about people's access to kind of tobaccos and lighters. Now, lighters are restricted items within the hospital, so we needed to obviously improve our systems in terms of management of lighters during admissions and post leave. And develop storage systems so that tobacco and lighters could be stored safely. We linked in with the pharmacy and the medics on the ward in relation to access and availability of NRT. We were proactive in using opportunities for brief interventions with patients in the build-up and post-launch day. And we obviously were trying to support people in a person-centered way. By listening to people's wishes and what people needed in terms of supporting them to become tobacco free. I think one of the focuses for us was not necessarily, it was about becoming tobacco free whilst they were an inpatient, because some of the feedback we received initially was that people didn't want to stop smoking. So the way we kind of worked with people is that rather than saying that this was necessarily smoking cessation, that this was just supporting them whilst they remained an inpatient. We also had to look at leave procedures and how we responded to breaches. I think going back to the NRT bullet point there, I know I've heard people talking about disposable vape pens, and essentially this is how we've achieved success, by making accessibility to disposable vape pens easy on the ward. So out of our ward budget, we procure the vapes that are on the screen there. I think they're called Dinner Lady vapes. Strange name, but they seem to be the ones that were most popular within the trust. So we procured, we have a regular order of vape pens that we order out of our budget, and we provide these free of charge to people, initially for the first 5 days or until people can access leave. And that I think that's been a game changer for us, the use of the vape pens, and the vape pens, from my experience, seem to be by far the most popular type of kind of product alternative to tobacco. In terms of responding to breaches, we had to reassure the staff about the concerns they had about all kinds of manner of concerns about how we respond if people have access to tobacco and lighters, and ensuring that we didn't approach that in a restrictive manner. So the staff on the ward have done a fantastic job of using their interpersonal skills and their professional relationships with patients about negotiating, handing in lighters and tobacco. And I think it's important for us that we've grown to learn that it's not just a case of announcing a launch date and becoming smoke-free. It's an ongoing process that will never end, because obviously patient flow is continuous, and it's an ongoing piece of work which will continue for us as a ward. And we needed to reassure people that we wouldn't be using restrictive practices to remove people's tobacco and and lighters, because that was a concern. Okay, next slide. So the reaction and response to launching the smoke-free ward has been really positive. Everyone's been really surprised at how well we've done so far on the ward. The 1st of November came and went. People handed in lighters, people handed in tobacco. We handed out vape pens to the people that wanted them, and it was a slight anticlimax. I don't think that's the right way of describing it, but it went so smoothly. People were just shocked. So the ward literally overnight turned from a ward where people were smoking in the garden to a smoke-free ward. So the staff feedback has been very positive about the environmental kind of changes. Obviously, because the garden was linked into the main lounge area, when people were smoking in the garden, the cigarette smoke was wafting into the building, and that was unpleasant for people. And obviously, the waste caused by cigarette butts is no longer an issue. So the physical environment is a much more pleasant environment. We do have regular, as I say, community meetings where we discuss this, and we have working together groups where we receive patient feedback. Feedback isn't always positive. There are people that feel that obviously they should be allowed to smoke whilst in hospital, and there's obviously a lot of debate that occurs about that subject. In terms of the incidents, I don't have any data for you, unfortunately, but what I can say is that since the launch date of the 1st of November, there's been very few incidents related to smoking on the ward. Again, it's difficult to kind of to explore that without the data available. But from my experience and working with Hannah, I can reassure anybody or tell you that the number of incidents in relation to smoking has been below 5, I would say, since November last year. Next slide. I think that's my last slide, actually. Yeah, so there you go. Thank you.
Brilliant. Thank you, Richard. Now I'm going to try and juggle questions. They were all fabulous presentations. And I'm going to start basically with questions for Mary. So Mary, can you talk about how you fund e-cigarettes? And are they provided by the trust for free? Are they free? Is it a mix?
Yeah, so we provide the e-cigarettes free of charge for all inpatients for the duration of their hospital stay. We haven't had any funding at all from the centre or from our commissioners, so it is entirely from the trust budgets, and we've been doing that since we established our smoke-free policy in 2014, largely because the leadership team at SLAM and the trust board in particular, our chairman, Sir Norman Lamb, are 100% committed to making sure every smoker quits as soon as possible and for good. So we can see our violence has reduced, our fires have been virtually eliminated across the organisation. No change in rates of detention, length of stay is reduced, everything is better. We are using less medications. There isn't anything I can think about that isn't better in a smoke-free world. So it's a small price to pay. We spend roughly about £180,000 a year on e-cigarettes, and we use the NHS framework for procurement and got our patients to select the e-cigarette. I notice Richard discussing the Dinner Lady e-cigarette. It is a fantastic product, but it is a disposable product, and that means we're producing a lot of waste if we're giving disposable e-cigarettes to all of our patients. We don't think every one of our mental health patients needs a disposable e-cigarette. So we want to get our patients onto the best e-cigarettes for them. So an individual, Hazel talked about tailoring the intervention. So I'm going to underline that point again and say we can't give a disposable e-cigarette to everyone, because that's not what everyone needs.
Yeah, thanks, Mary. That's really helpful. And for funding, you know, Richard, you were saying you're funding it too. So you using the same process in terms of where you're getting the funding from?
For now, that's our plan for Regency Ward. Obviously, with the Trust's current recruitment process, recruiting a lead for tobacco dependency, things may change in the future. This is just our approach on Regency Ward. It's coming from our budget, and we think it's a small price to pay to stop people smoking cigarettes.
Thank you, that's really helpful. Aideen, I've been asked by people about how they can get on your list for the mobilisation emails. So we'll provide that information, but if you want to put it in the chat as well, where people need to get in touch to do that, I think that would be helpful. And next for, let me see, for East London, there was questions on training and how the training is taking place. So is that NCSCT training, and how do you do it?
Yeah, I think we popped some quick answers in the chat, but Ogechi can update us.
Yeah, so
not everyone will have had a chance to read the chat, so we want to make sure everything's covered.
So it would be through the NCSCT website, and I've tailored a package and training to deliver amongst the different sites in ELF, and the other tobacco advisors per directorate. They would have face-to-face training tailored to how ELF runs their tobacco services.
Sorry.
I was just going to say there was a question about coverage as well. So how many staff, what proportion? And I think Ogechi did a great job of getting it up to almost 90% of staff, but then with staff turnover, it dropped down to 60-odd%.
Thank you, that's very helpful. There was a question about modelling and local authorities stop smoking services, and I think, is it Sally Macvinish came back with an answer? So Sally, can we come to you for that?
Yeah, so this is something that one of my colleagues did before I got to work in ELF, and something that we've discussed with Aideen as well, for the community side of things. So essentially what they did was look at our admitted patient care spells, which we have available on our usual system. So we use Rio, and it's available on Power BI. So we know monthly how many inpatients we have. We then looked at the proportion of those that were smokers. We know that our data isn't great on this because we don't have that 100% smoking status data yet. So we used national estimates of our smoking prevalence to give us a number of smokers. And then we just made some assumptions about the proportion of people who would engage with our services. So the proportion who would engage with Ogechi while they're an inpatient, and then the proportion that we thought would continue to engage in our model with our ELF community stop smoking advisors. But if you didn't have community-based mental health trust advisors, you could make an assumption about what proportion would continue to engage with the local authority, which obviously would depend on the proportion that are currently engaging and whether you've got any additional support there to help them to facilitate them into those local services. But at the moment, it's guesstimate work on the model.
Thank you, that's very helpful. And to come back to Aideen for a question for you, have you developed expected measures of success for the community mental health programme? What are your, have you got a set target for what you expect to happen to smoking cessation, to smoking prevalence rates, where you think they are now and where they need to get to?
So we haven't set targets or trajectories. What we have done is we've developed a kind of evaluation plan with partners during a recent task and finish group. So that's defining what our key outcome measures are. But in terms of measuring impact, it will be very much, we'll be using the patient level data collection system that's being developed for the inpatient offer and using that to monitor. We haven't discussed targets or trajectories, so it's not something that we've discussed as yet. What we do want to do is have quite a tight evaluation plan around this. So looking at process evaluation, early insight, what's coming out of the early implementer sites, impact evaluation in the short term, and then that longer term cost and cost effectiveness. I think it'd be really difficult to set expectations right now in terms of what we would expect the services to deliver without having that kind of standard or benchmark.
Thanks, Aideen. And someone asked the question about whether people with learning disabilities and autism are included. Now, I know the long-term plan includes learning disabilities, but I don't know the answer on autism. Can you help?
Yeah, so I think it's really interesting that the phrasing of the LTP commitment includes SMI and LD. They're very different group patient cohorts or client cohorts. And what we said very early in a policy paper to the NHS Prevention Board is we have an idea of what good looks like in SMI, but we don't know what the prevalence is in LD, and we don't know what good looks like for people with learning disabilities. And so what we want to do alongside mobilising the SMI service is to do some scoping work, understanding the proportion of people with SMI and learning disabilities, understanding what their needs around support to quit look like. And I think that the definition as well, so scoping who is included in that definition of people with learning disabilities. So it's a little bit of a vague answer, but I think what we agreed was that we didn't have enough evidence right now to commission something or to mobilise something, but we do want to do a bit of scoping work to understand that cohort group a lot more before we then do something.
Can I clarify? Because I assumed it was SMI and learning difficulties. But the way you said it implied people with SMI and learning difficulties at the same time, but that's not.
So how we've interpreted at the moment is that people with severe mental illness who also have learning disabilities. But if you're looking at a separate offer for everybody with learning disabilities, not just those with SMI, that there is a big gap around what does that look like and what are the needs. So the next step for us is that scoping piece of work to understand both. So it is understanding learning disabilities, but also looking at what proportion of people with SMI have learning disabilities. So is there something we can do within the existing services that we're mobilising? And then is there something about what an offer looks like? But as I said, my understanding and having spoken to some kind of key people in this area is that not a lot is known about this cohort. So we do need to do some scoping and insight work. And
one other quick question, because the community element, I assumed, well, I had read was for everyone with a long-term mental health condition, and I didn't assume all of those would be defined as SMI, but or come within that definition. So is the community offer going to be broader than just SMI or not? So
we haven't defined the population, and I think that's down to systems to decide how they open access to these services. So if you're doing the primary care model and you're using physical health checks, then it's probably going to be people with a diagnosed serious mental illness or severe mental illness, because they'll be on the SMI register for receiving a physical health check. Within the other models, we haven't defined whether or not they have to have a diagnosis. It's up to the local system to decide where there's a level of need that would require that specialist support in tackling tobacco dependency.
Thank you. And there was a question about storage and difficulties in storage. Now, I know people often say, well, SLAM's different because SLAM is, you know, SLAM is SLAM. But Richard was saying you didn't have problems with that. And I wondered if you just wanted to go into that, and also whether that's relevant to East London or whether that's not an issue you've dealt with yet. So Richard first, then East London.
Yes, so again, I have a caveat. So this is our interim. This is our interim approach. Obviously, we will be looking at how we manage this in the future. In order to go smoke-free as soon as possible, what we have is in our ward nursing station, we have each patient on the ward has a locker, where we securely store their tobacco. For people, and it's stored there. I know I can see people smiling because I know that's probably controversial, but that's how we're managing it in the short term. And I'm aware people probably do it differently elsewhere, but for us, that's working for the time being. It will be reviewed when people have Section 17 leave or want to leave the ward. We provide them with their tobacco if they want it. And we ask them to return it when they return to the ward.
Okay, East London, and then I'll come to Mary for her comment.
So I remember attending meeting Mary at SLAM a couple of years ago about facilitating smoking. Having lockers was one of them. So here at ELF, we've tried to mitigate that, but that's come with some violence and aggression and increase in incidents from some of the patients. So what we try to do is, whilst they're on admission, that we confiscate it, so to speak, depending on the patient group that's admitted. It's kept in their locker, it's not destroyed, because they talk about human rights a lot. So there's that issue that we're trying to, the temperament balance of safety and risk against staff of violence and aggression, and also ensuring that the patient knows that this is considered contraband because it's not safe to, it's not to be admitted on the ward. When they do go out, Section 17, we try to follow a model used up in the northern part of England, where they permit that in Section 17 smoking should not be allowed as part of their leave. Again, that's been met with some resistance from both staff and patients because of the term is my human right, even though it's nowhere written in the Human Rights Charter. So that's where we're at now. We're still, hopefully, maybe Mary can share some pointers in how to get rid of that.
Mary, I'm going to have to ask you to be very brief, no more than 30 seconds, because we're coming to the end and I need to wrap up. I should have done it 5 minutes ago. So very quickly. Oh, you're mute.
Oh, so sorry. I think it's very important not to store tobacco because it undermines all of our efforts. It shows to our patients that we really don't care about them at all, and we don't have confidence in them if we don't think they can do it. If I've got their tobacco in the office, then it's going to create conflict and they will want to keep coming back for it. And they will never use the NRT or the e-cigarettes if they've got the option to have their cigarettes. So for me, it's an essential part of our programme. We need to be brave. We need to do it. It is the right thing to do. And once we do it, everything becomes easier.
Thanks, Mary. I'm going to wind up now, and I'd just like to say thank you to all the brilliant speakers. And just to say that Mary talked about the journey she'd come on, and she showed a picture of someone in an iron lung being helped to smoke. And we've come a long way from that, but it is a journey. And I remember when I first started on the campaign for smoke-free places, a public health doctor telling me that as a GP in the 1950s, he was recommending pregnant women to take up smoking to ward off morning sickness. So we've come a long way from that. And I think mental health has been, has taken longer to get on that journey, but we're a lot further on that journey than when we all first started working on this. So thank you all very much. The presentations will be up, and so will the slides and everything. And this is the beginning of, I think, many more presentations like this to come, and the journey will carry on. Thank you.